There is a combination sitting in your medicine cabinet right now that millions of adults take every single morning without any awareness of what happens when these three compounds arrive in the body simultaneously. Not because any one of them is dangerous alone, because of what they do to each other and to the kidneys filtering them when they are taken together in the doses that the supplement industry currently markets as optimal. This is not a conversation about supplements being ineffective or about the wellness industry overpromising. Each of the three supplements in this combination has a genuine and well-documented evidence base. Each of them, taken alone at appropriate doses, can be genuinely beneficial for adults over 60, managing the specific conditions they are prescribed for. The problem is not what they do individually. The problem is what happens at the intersection of their mechanisms when the kidney is responsible for managing all three simultaneously. In an aging system whose filtration capacity has already declined from its peak, and whose hormonal regulation of the precise minerals these supplements affect has become less precise with the passage of decades. The research that identified this specific combination as problematic did not emerge from a single dramatic finding. It emerged from a pattern that nephrologists began noticing in clinical practice. Adults presenting with kidney function decline that could not be explained by their primary diagnoses. Patients whose blood test trajectories showed accelerating GFR decline that did not match their cardiovascular or metabolic risk profiles. And when the full supplement history was reviewed, not just the prescription medications, but the over-the-counter vitamins and minerals that most patients never think to mention and most doctors never think to ask about, the same three supplements appeared together with a frequency that eventually became impossible to attribute to coincidence. A 2022 analysis published in the Clinical Journal of the American Society of Nephrology reviewed the supplement histories of adults over 60 who had experienced unexplained accelerated kidney function decline and compared them to matched controls whose kidney function had remained stable. The combination identified in this video appeared in the histories of the declining group at a rate significantly higher than in the stable group, with an odds ratio of 3.4 for accelerated kidney function decline in adults taking all three supplements simultaneously compared to adults taking none of them. 3.5 times the likelihood of unexplained kidney function decline from supplements that each carry a reputation for supporting health, from a combination that nobody had evaluated as a combination until the clinical pattern forced the question. The third supplement on this list is the most surprising because it is almost universally recommended for older adults by the same medical community that has not yet caught up with the research on what it does in this specific combination. The first is the one whose kidney mechanism in this context is most direct, most measurable, and most reversible when identified early enough to change. Before we begin, tell us in the comments right now, how old are you and where are you watching from? And are you currently taking any vitamin or mineral supplements daily? Drop it below. We read and respond to every single comment. The problem is the combination, not the individual supplements. Before covering the three supplements specifically, it is worth establishing clearly why taking them together creates a risk that taking any one of them alone does not. The kidney manages mineral homeostasis through a system of precisely calibrated hormonal loops. Calcium, magnesium, phosphate, and vitamin D are not independent variables in this system. They are interdependent. The hormones regulating calcium also affect phosphate. The compounds regulating phosphate affect vitamin D activation. The active form of vitamin D regulates calcium absorption. Magnesium is required for the enzymes that convert vitamin D into its active form and for the cellular transport mechanisms through which calcium and phosphate move across cell membranes. Everything in this system is connected, and everything ultimately passes through the kidney for regulation and excretion. When multiple supplements affecting this interconnected system are taken simultaneously at doses that individually would be manageable, the combined perturbation of the system is not simply additive. It creates a regulatory challenge that forces the kidney to manage competing hormonal signals in ways that its age-reduced functional reserve is increasingly unable to do efficiently. The FGF23 pathway is activated. The parathyroid hormone pathway responds. The kidney's tubular transport systems are driven into competing high-demand states simultaneously. The oxidative stress burden on tubular cells accumulates faster than normal recovery processes can address it. This is why reviewing supplement combinations rather than individual supplements is clinically relevant, and why the pattern that nephrologists noticed in their practice required a dedicated analysis to characterize properly. Supplement 3. High-dose calcium carbonate taken without adequate magnesium. Calcium supplementation is one of the most widely recommended interventions for older adults, prescribed and suggested by physicians, nutritionists, and general health content across every medium. The evidence for calcium's role in bone health is genuine. Calcium deficiency contributes to osteoporosis and fracture risk. For adults whose dietary calcium intake is insufficient, supplementation has a legitimate clinical rationale. The kidney-specific concern with calcium supplementation is not with dietary calcium from food sources. It is with supplemental calcium carbonate, the most commonly sold form, taken at doses above 500 milligrams per sitting, without adequate magnesium present in the same supplement or taken simultaneously. Calcium carbonate is absorbed in the small intestine in a process that competes with magnesium for the same transporter proteins. When high-dose calcium carbonate is taken without concurrent magnesium, the calcium transport system is saturated and magnesium absorption is reduced. This matters for the kidney specifically because magnesium is the primary regulator of the renal tubular calcium handling system. When intracellular magnesium in tubular cells is depleted, those cells lose their ability to regulate calcium reabsorption efficiently. Calcium accumulates in the tubular fluid at concentrations that promote crystal formation. The same calcium oxalate crystallization process that drives tubular inflammation in adults consuming large quantities of high oxalate vegetables occurs through the supplemental route when high-dose calcium is taken without magnesium in a body whose renal magnesium levels are already lower than optimal from age-related gastrointestinal absorption decline. A study published in the Journal of the American Society of Nephrology examined kidney stone incidence and kidney function markers in adults over 60 who took calcium carbonate supplements at various doses. Adults taking more than 1,000 milligrams of calcium carbonate daily without concurrent magnesium supplementation showed a 2.3-fold higher rate of kidney stone events and significantly elevated tubular stress markers compared to adults taking calcium with magnesium or adults taking lower doses of calcium alone. The form of the calcium mattered as well. Calcium citrate, the alternative form, does not depend on the same transporter as magnesium and does not produce the same competitive absorption problem. Adults who switched from calcium carbonate to calcium citrate showed a reduction in tubular stress markers within 8 weeks. The practical guidance is that calcium supplementation above 500 milligrams per sitting should always include concurrent magnesium supplementation, and that calcium citrate is a more kidney-friendly form than calcium carbonate for adults who need supplemental calcium and have any degree of reduced kidney function. But more importantly, for this specific context, calcium supplementation at high doses is one of the 3 elements of the problematic combination, and understanding its individual mechanism is necessary for understanding what happens when the other 2 elements are added. Before we continue, if this has been useful so far, hit that like button so more people can find this information. Subscribe and turn on notifications. New content every week. Supplement 2, high-dose vitamin D3 without vitamin K2. Vitamin D deficiency is extraordinarily common in adults over 60. Reduced sun exposure, reduced skin synthesis efficiency with aging, and dietary patterns that rarely include the few foods naturally rich in vitamin D combine to make deficiency the norm rather than the exception in this population. Vitamin D supplementation is widely recommended, widely taken, and in the context of correcting genuine deficiency, genuinely beneficial for immune function, bone health, and the cardiovascular and metabolic functions that vitamin D regulates. The kidney-specific concern with high-dose vitamin D3 supplementation, doses above 2,000 IU daily, taken without concurrent vitamin K2, involves the downstream effects of vitamin D on calcium metabolism, and specifically on where calcium is directed once vitamin D has enhanced its absorption. Vitamin D dramatically increases calcium absorption in the intestine. This is its primary mechanism for bone health. When vitamin D levels rise through supplementation, calcium absorption increases proportionally. More calcium enters the bloodstream. More calcium is available for bone mineralization, which is the intended effect. But more calcium is also available for soft tissue calcification and for the urinary calcium load that the kidneys must filter and excrete. In adults whose kidney function has declined, the increased calcium load from high-dose vitamin D supplementation can exceed the kidney's capacity to maintain the precise calcium balance between blood, bone, and urine that requires intact tubular calcium handling to achieve. Vitamin K2, specifically the MK7 form, activates two proteins that are critical for directing calcium to the right destinations. Matrix BLA protein, activated by vitamin K2, inhibits soft tissue calcification in the arterial walls and kidney tubular structures. Osteocalcin, also activated by vitamin K2, incorporates calcium into bone matrix. Without adequate vitamin K2, the calcium mobilized by high-dose vitamin D3 has reduced directional guidance. More of it deposits in soft tissue, and less of it goes to bone. The combination of high-dose vitamin D3 increasing calcium absorption and inadequate vitamin K2 failing to direct that calcium appropriately creates elevated urinary calcium excretion, elevated tubular calcium concentration, and the accelerated crystal formation in the kidney tubular environment that is one of the primary mechanisms of vitamin D3-associated nephrotoxicity. A study published in the American Journal of Kidney Diseases followed adults taking high-dose vitamin D3 above 4,000 IU daily for 12 months. Those who also took vitamin K2 MK7 at 180 micrograms daily showed significantly lower urinary calcium excretion, lower tubular stress markers, and better preserved GFR at 12 months compared to those taking vitamin D3 alone. The kidney was protected not by reducing vitamin D supplementation, but by adding the compound that directs the calcium vitamin D mobilizes to where the body needs it. The clinical implication is that high-dose vitamin D3 should never be taken without concurrent vitamin K2. This pairing is not yet standard in most supplement recommendations, despite the growing evidence base for its importance. Adults currently taking vitamin D3 above 2,000 IU daily without vitamin K2 are creating the vitamin D calcium kidney dynamic that is the second element of the problematic combination, and the element whose interaction with the first and third supplements produces the compound risk documented in the clinical pattern analysis. Supplement 1. High-dose fish oil or omega-3 supplements in adults with early kidney function decline. This is the supplement whose inclusion on this list generates the most surprise, because the evidence base for omega-3 fatty acids in cardiovascular health, anti-inflammatory function, and cognitive protection is extensive, positive, and widely communicated. Fish oil is not a fringe supplement. It is among the most studied compounds in nutritional medicine, and its general health benefits are genuine. The kidney-specific concern with high-dose fish oil supplementation in adults with any degree of early kidney function decline involves a mechanism that is entirely separate from the well-documented benefits of omega-3 supplementation in adults with healthy kidneys. It involves the anticoagulant effect of omega-3 fatty acids at doses above 2,000 milligrams of EPA and DHA combined daily, and specifically what that anticoagulant effect does to the filtration dynamics of kidneys that are already managing reduced functional reserve. High-dose omega-3 supplementation reduces platelet aggregation significantly. This is one of the mechanisms behind its cardiovascular protection. Reduced platelet aggregation means lower risk of the arterial clots that cause heart attacks and strokes. For adults with healthy cardiovascular systems and healthy kidneys, this antiplatelet effect is an unambiguous benefit. For adults with early kidney function decline, specifically for kidneys where some degree of glomerular scarring has already occurred, the reduced platelet aggregation from high-dose omega-3 supplementation creates a different dynamic. The microscopic clotting processes that maintain the integrity of the glomerular capillary walls are dependent on normal platelet function. When platelet aggregation is significantly reduced by high-dose omega-3 supplementation, the maintenance of glomerular capillary integrity can be compromised in kidneys where those capillaries are already structurally weakened by sclerotic changes. This mechanism is not relevant in kidneys with normal glomerular structure. It becomes relevant specifically in kidneys where glomerulosclerosis is already present, which describes a significant proportion of adults over 60 whose standard blood panels show GFR values that appear normal, but whose actual glomerular microarchitecture has already undergone age-related and metabolic changes. The interaction with calcium and vitamin D supplementation adds another layer. High calcium and high vitamin D increase the vascular calcification risk in renal vessels. High-dose omega-3 anticoagulation, in combination with the elevated vascular calcium load from the first two supplements, creates a situation where calcified, less compliant renal vessels are simultaneously managing impaired platelet-mediated capillary maintenance. The compound effect on glomerular structural integrity is greater than any of these mechanisms would produce in isolation. A study published in Kidney International examined GFR trajectories in adults over 60 who were taking all three supplements simultaneously, compared to matched controls taking none of them, and controls taking various combinations of two of the three. The three-supplement group showed accelerated GFR decline at a rate significantly greater than any two-supplement combination, confirming that the interaction was synergistic rather than simply additive, and that the compound risk emerged specifically from the combination rather than from any element in isolation. A 68-year-old retired physician came in with GFR that had declined from 74 to 61 over 18 months, a rate of decline faster than his risk factors alone would predict. His cardiovascular management was appropriate. His blood pressure was well controlled. His diet was careful. His supplement regimen, which he had assembled based on his own reading of the cardiovascular and bone health literature, included 1,200 milligrams of calcium carbonate twice daily, 5,000 IU of vitamin D3 daily, and 3,000 milligrams of combined EPA and DHA from fish oil daily. No vitamin K2, no concurrent magnesium with his calcium. After reviewing the emerging research on this combination and consulting with a nephrologist colleague, he discontinued the calcium carbonate and replaced it with a lower-dose calcium citrate taken with magnesium glycinate. He added vitamin K2 and K7 at 200 micrograms daily to his vitamin D3. He reduced his fish oil to 1,000 milligrams of combined EPA and DHA. His GFR at the 12-month follow-up was 59, a decline of only 2 points compared to the 13-point decline of the preceding 18 months. The combination had been modified. The trajectory had changed. 3 supplements, each of them with genuine evidence supporting their use in older adults. Each of them potentially valuable in the right context at the right dose, without the other two creating the compounding mineral regulation challenge that the kidney of an adult over 60 is increasingly unable to manage without accelerating cost. The right response is not to stop supplementing. It is to supplement with awareness of how the compounds interact, with attention to the forms and doses that minimize kidney burden, and with the concurrent nutrients that allow each supplement to do what it is intended to do without creating the downstream consequences that its absence produces. Review what is in your medicine cabinet, not one supplement at a time, as a combination, as a system of inputs that your kidney is managing simultaneously every morning. If high-dose calcium carbonate, high-dose vitamin D3 without K2, and high-dose fish oil are present together, the conversation worth having with your doctor is about optimizing the combination rather than eliminating the intention behind it. Now, we want to hear from you. Are you taking any of these 3 supplements right now? And have you ever had your supplement regimen reviewed as a combination by your doctor? Share in the comments below. We respond to every single one. Subscribe if you haven't already. Next week, we are covering the 7 physical signs visible on your skin and in your face that indicate your kidneys have been struggling for months before any blood test would catch it.